This is ABSITE and board review for bile duct and gallbladder. Let's start with anatomy. The parts of the gallbladder are the fundus, body, infundibulum, and the cystic duct. The bile duct above the cystic duct is called the common hepatic duct, and below it, it is called the common bile duct. The cystic artery comes from the right hepatic artery, which usually passes posterior to the common hepatic duct. The triangle of Callot is made up of the inferior border of the liver, the common hepatic duct, and the cystic duct. The triangle of Callot contains the cystic artery. The gallbladder has no submucosa. The submucosa is the strongest layer of the small intestinal wall, so the gallbladder is less strong than the small intestine. The gallbladder actively absorbs sodium chloride and water follows passively. Bile is concentrated in the gallbladder in this way. The gallbladder squeezes in response to secretin and somatostatin. Morphine causes contraction of the sphincter of Oddi, whereas glucagon causes it to relax. The total bile acid pool is about 5 grams, and you lose about 5 to 10% of this each day in the stool. The other 90% is recirculated from the terminal ileum through the portal venous blood and back to the liver. This process is called the enterohepatic circulation. Bile acids and bile salts are made from cholesterol. The common bile duct and cystic duct do not have any peristalsis. The normal diameter of the common bile duct is 5 to 8 millimeters, and you can see a 10 millimeter bile duct after cholecystectomy and in the elderly, since it can expand about 1 millimeter per year after age 50. The thickness of the gallbladder wall is around 4 millimeters, and the pancreatic duct is also around 4 millimeters. Gallstones occur in about 10% of people, but the majority are asymptomatic. Risk factors for gallstones are the F's: female, age around 40, fertile as in recently pregnant, fat or obese, and rapid weight loss. The most common form of stones are cholesterol stones. The second most common gallbladder stones are black pigmented stones. These are caused by hemolytic disorders, cirrhosis, and chronic TPN. Brown pigmented stones are usually found as primary bile duct stones, and they are related to infections in the bile. Acute cholecystitis is due to obstruction of the cystic duct by a gallstone. If somebody has acute cholecystitis, the gallbladder wall will be thickened more than 4 millimeters. They can have pericholecystic fluid, and they can have pain with pressure with an ultrasound probe, causing an inspiratory arrest called a Murphy's sign. Rotensky-Aschoff sinuses are seen microscopically in gallbladder wall in acute cholecystitis. Severity of acute cholecystitis can be calculated with the Tokyo guidelines. These were revised in 2018 and they're sometimes abbreviated TG18. Gangrenous cholecystitis is when there is necrosis and gas-forming organisms in the wall of the gallbladder, and this may show up on imaging with air in the gallbladder wall. This is known to have a worse outcome, and urgent cholecystectomy, if you can, is a good idea. The most sensitive confirmatory test for acute cholecystitis is a HIDA scan. HIDA scans will show no filling of the gallbladder because the cystic duct is obstructed with a stone and inflammation, so the HIDA dye can't get into the gallbladder. If no bile can get through an obstructed cystic duct but the gallbladder wall continues to produce mucus, then a white fluid in the gallbladder is called hydrops of the gallbladder. Acute cholecystitis is treated with cholecystectomy, or if the patient is too sick, you can place a cholecystostomy tube into the gallbladder with interventional radiology. Next, let's talk about choledocolithiasis. Choledocolithiasis is when a gallstone is blocking the common bile duct, and this does not necessarily have to be causing an infection. Choledocolithiasis can be diagnosed with a dilated common bile duct and possibly seeing a stone in the common bile duct on ultrasound. MRCP can show the dilated bile duct and the obstructing stone also. Ascending cholangitis is infection of the main biliary tree. This is often associated with choledocolithiasis, but it can occur with anything that obstructs the flow of bile. Cholangitis can present with Charcot's triad, which is fever, right upper quadrant pain, elevated bilirubin, or jaundice. If the patient is septic, then they can have Raynaud's pentad, which is hypotension and altered mental status, along with the Charcot's triad symptoms. Choledocolithiasis is an emergency, and it's treated with ERCP and stone extraction as soon as possible. If a patient is too septic, another option is a percutaneous transhepatic cholangiography, or a PTC drain, which will drain bile out through the liver. If neither of these are possible, then you should do a surgical common bile duct exploration. You can try a cholecystectomy with a transcystic duct common bile duct exploration, but this is difficult and is likely to not work very well. An open common bile duct exploration is a much more common actual surgery to relieve choledocolithiasis with or without cholangitis that is not a candidate for an ERCP. A common bile duct exploration is done by making a ductotomy with a blade or scissors. This is done on the anterior common bile duct below the cystic duct junction. Avoid cautery to open the duct because you don't want to cause stricture and necrosis of the common bile duct. You do the anterior cut to stay away from the 3 and 9 arteries that supply blood to the common bile duct. These tend to run on the sides of the common bile duct. Then you either push the stone through the ampulla into the duodenum or remove it through the ductotomy with a Fogarty balloon or a basket. Sometimes cochorizing the duodenum and using a finger palpation to push the stone out can also help. Then place an 8 or a 10 French T-tube into the bile duct, and sometimes you need to stitch the ductotomy together to hold the tube in place. The T-tube exits through the abdominal wall and is put to drainage. In 6 weeks, you should do a T-tube cholangiogram to be sure there is no obstruction or stricturing of the bile duct, and then you can pull the T-tube after that. Remember to use absorbable suture like PDS on the common bile duct to prevent a nidus for future stone formation. If you cannot remove an impacted distal common bile duct stone, and you have already made an anterior bile duct ductotomy, I would consider a choledochoduodenostomy to the duodenum to provide biliary drainage, and in that case you may just end up having to leave the impacted common bile duct stone in the distal common bile duct. Gallstone ileus is a favorite question on ABSITE. This is due to a fistula between the gallbladder and the duodenum, through which a stone passes and obstructs at the ileocecal valve. Wriggler's triad is a radiopaque object in the right lower quadrant, a small bowel obstruction, and air in the biliary tree. The surgery for gallstone ileus is to milk the stone backwards to a piece of ileum that is not inflamed, make an enterotomy to remove the stone, and close the enterotomy in a transverse fashion. I would be very cautious about operating on the gallbladder and trying to remove the cholecystoduodenal fistula, as this is a difficult surgery and most of the time I would just leave that area alone. A less common problem is a fistula between the gallbladder and the area of the pylorus, in which a gallstone obstructs the pylorus of the stomach. This is called Mirizzi Syndrome. Quincke's triad is sudden upper GI bleed with jaundice and right upper quadrant pain. This is due to a hepatic artery to bile duct fistula, usually caused by previous liver trauma. Treat with IR angiography and embolization of the bleeding hepatic artery branch. A common question thread is postoperative cholecystectomy problems. One common scenario is a patient who underwent a laparoscopic cholecystectomy and they come in a few days later with right upper quadrant pain. The initial workup for this should always be a right upper quadrant ultrasound and liver function tests along with basic labs. If there is a fluid collection on the right upper quadrant ultrasound, you should probably place an IR drain into this to see if it is bile. If it is a biloma, but it stops draining after the IR drain is placed, then nothing else needs to be done. But if it continues to leak bile, the patient needs an ERCP with dye injection to see where the leak is coming from. Areas of leakage could be the cystic duct stump, or an injury to the common bile duct itself, or a duct of Luschka in the gallbladder fossa. The classification of bile duct injuries is according to the Bismuth-Strasberg classification. These are based on injury to the minor ducts or an aberrant right hepatic duct or a main hepatic duct. Most small leaks from places such as the cystic duct stump or a duct of Luschka will respond to sphincterotomy and stent placement by ERCP and having the biloma drained with the IR drain. If the patient's initial workup shows no fluid collection, but there's a very dilated bile duct and an elevated bilirubin, this is also concerning for a common bile duct injury. Main common bile duct or common hepatic duct injuries are known as type E injuries in the Bismuth-Strasberg classification. MRCP and ERCP are good confirmatory tests. If there is a common bile duct injury and it's been less than 7 days since surgery, most would recommend immediate re-exploration for hepaticojejunostomy. If it has been more than 7 days, there is going to be a lot of adhesions, and you should consider placing a PTC drain to drain the bile out of the liver and wait about 6 weeks before attempting repair. This gives it time to allow the adhesions to soften. If you're going to do that, I would strongly consider mentioning tertiary referral center for a biliary surgeon to do the re-exploration. A subset of this question is what to do if you notice a common bile duct injury during the index surgery, the first cholecystectomy surgery. If you damage the common bile duct and it is less than 50% of the diameter, you have two options. The first would be a primary repair with absorbable sutures such as PDS. However, if you do not think that you can do this without stricturing the bile duct, or if you were worried there was some cautery damage to the bile duct, it may be safer to place a T-tube through the injury itself and leave it in place for about 6 weeks. However, if you've noticed that you have transected the bile duct with more than 50% of the circumference, probably an immediate conversion to a Roux-Y hepaticojejunostomy is the best answer. For this, the distal bile duct is tied off. A 40 to 60 centimeter Roux-Y limb is created from the jejunum, and an end-to-side anastomosis between the common hepatic duct and a Roux-Y limb is made, usually with a single layer of 4O PDS suture. You should know about choledochal cysts. The vast majority of these are treated by pediatric surgeons, but occasionally you will actually find adults who have undiagnosed ones. In a pediatric patient, choledochal cyst will present as jaundice with a palpable right upper quadrant mass. All choledochal cysts are removed because they increase the risk of bile duct cholangiocarcinoma. Gallbladder cancer is also increased in these patients, so most people recommend removing the gallbladder and any choledochal cyst, no matter what type of surgery you're doing for them. Type 1 choledochal cyst is a fusiform dilation of the entire extrahepatic bile duct from the bifurcation down to the retroduodenal bile duct. You need to remove the dilated bile duct from the bifurcation down through the intrapancreatic bile duct, and this requires a hepaticojejunostomy. This would usually involve a cholecystectomy too, obviously. A type 2 choledochal cyst is a small saccular outpouching of the bile duct. These are treated usually with diverticulectomy of the outpouching itself. You should probably also go ahead and remove the gallbladder while you're doing that. Type 3 choledochal cysts are called choledochocele. These are an enlargement near the sphincter of Oddi in the very distal common bile duct. These are treated usually with just endoscopic sphincterotomy. You could probably also do a cholecystectomy. Type 4 is multiple intra- and extrahepatic biliary dilations. These are sometimes treated with extrahepatic bile duct excision, but some also need liver transplant. Type 5 choledochal cyst is also called Caroli's disease. This is totally intrahepatic dilations, and these patients are commonly put on liver transplant lists. Primarysclerosing cholangitis, or PSC, is multiple strictures of the hepatic ducts. This can lead to obstructive jaundice and eventually liver failure. PSC is related to ulcerative colitis. Remember that colon resection does not make the PSC go away. PSC patients may need a liver transplant. Primary biliary cirrhosis, or PBC, occurs in women, It leads to progressive biliary obstruction and cirrhosis. It's caused by antimitochondrial antibodies, and these also often end up needing liver transplant. Next, let's talk about Mirizzi Syndrome. Mirizzi Syndrome is blockage of the common bile duct by a gallstone stuck in the neck or the cystic duct of the gallbladder. There's an increased risk of this if there's a long cystic duct that runs parallel to the common hepatic duct. There are 5 types according to the Sezendez classification. Type 1 is obstruction of the common bile duct without a fistula between the gallbladder and the common bile duct. Type 2 means that there is a fistula between the gallbladder neck or the cystic duct and the common bile duct, but the fistula involves less than 1/3 of the circumference of the common bile duct. Type 3 is a fistula that is between 1/3 and 2/3 of the common bile duct. And type 4 is a complete fistula involving the entire common bile duct, and this would need a full biliary reconstruction with a Roux-Y hepaticojejunostomy. Lastly, type 5 is any Mirizzi syndrome that's also associated with a fistula to the duodenum or the stomach. If a patient has gallstones and a dilated common bile duct above the level of the cystic duct junction but no distal common bile duct dilation, I would consider Mirizzi syndrome. A good confirmatory test is MRCP. In a test or a board exam, I would answer that for any Mirizzi syndrome, I would do an open surgery. The anatomy is usually very distorted and the porta hepatis has a lot of inflammation in it. Obviously, this depends on the surgeon's laparoscopic skills, but open surgery is probably a safer answer. I think a good option for some Mirizzi syndromes, such as a type 1 through a type 3, is to do a subtotal cholecystectomy. You got to remove the impacted stone, and you actually leave flaps of the gallbladder to suture together over the area of the common bile duct or the common bile duct fistula area. You got to remember to remove the impacted obstructing stone in the common bile duct, obviously. Just be sure you are not stricturing the common bile duct with this, and use absorbable suture. Gallbladder polyps should be treated with a cholecystectomy if the polyp is over 1 centimeter in size or it's causing symptoms. You can tell the difference between a polyp and gallstones by having the patient move around. Polyps don't move and don't roll towards the dependent portion of the gallbladder. Gallbladder cancer is the most common type of biliary cancer. Risk factors for gallbladder cancer include certain ethnicities such as Native American and having a history of large gallstones, which typically over 3 centimeters in size is a big risk factor. Porcelain or a calcified gallbladder wall is also considered a risk factor and is an indication for cholecystectomy itself. If you find a gallbladder cancer incidentally after a lap chole, you do not need to do anything else if the cancer is not penetrating into the muscularis propria of the gallbladder wall. These are known as T1A gallbladder cancers. If the cystic duct margin is also negative, then the gallbladder cancer is basically treated just with the cholecystectomy and no further surgery is needed. However, if the gallbladder cancer is penetrating into the muscularis layer of the wall or past this would be a T1B or anything higher T stage than this, then you do need to reoperate and do a radical cholecystectomy. Radical cholecystectomy involves doing a wedge resection of segments 4B and 5. You need to be sure the cystic duct margin is clear, or else you may need to do a common bile duct excision and hepaticojejunostomy. You should also do a portal lymphadenectomy, specifically focusing on the retrohepatic lymph nodes posterior to the common bile duct and those in the retroduodenal position. Gallbladder cancer does not respond very well to chemotherapy or radiation, although they are both commonly used in an adjuvant fashion anyway. The next bile duct cancer type is cholangiocarcinoma. Cholangiocarcinoma is referring to bile duct cancer that occurs in either the intrahepatic bile ducts or the extrahepatic bile tree. Risk factors for bile duct cancer include choledochal cysts, Primarysclerosing cholangitis, and chronic bile duct infections or irritation of the bile duct. Only about 1/3 of cholangiocarcinomas are in the intrahepatic bile ducts. These typically present as infiltrative lesions around an intrahepatic bile duct, and they're treated with liver resection if at all possible. Rarely are intrahepatic cholangiocarcinomas offered liver transplant due to a high recurrence risk. 2/3 of cholangiocarcinomas are in the extrahepatic bile duct. Most of these are actually in the area of the hepatic bifurcation and are commonly known as Klatskin's tumors. Klatskin tumors are classified according to the bismuth classification. A bismuth 1 is just below the hepatic bifurcation, and a bismuth 2 is involving the hepatic bifurcation. Bismuth 3A extends from the bifurcation into the right hepatic duct. This would require a resection of the extrahepatic biliary tree along with a right hepatic resection as well. Bismuth 3B is extending into the left hepatic duct, which would require a left hepatic resection along with common bile duct excision. A bismuth 4 extends into both of the intrahepatic bile ducts, including the bifurcation, and this would be considered unresectable. Other unresectable cholangiocarcinomas would include direct invasion and encasement of the hepatic artery or the portal vein, or any metastatic disease. For a bismuth 1 or a bismuth 2 Klatskin tumors, all you really need to do is resect the extrahepatic bile duct, and you may need to follow this into the intrahepatic bile duct in order to get negative margins, and this would require a biliary reconstruction such as hepatocogenostomy. The last location for an extrahepatic cholangiocarcinoma is in the distal common bile duct in the area of the intrapancreatic bile duct. These are treated usually with just a Whipple surgery. I hope that helps. Good luck.